Hello all, welcome to my show Chronicles of a Learner RN, and thank you for listening. My name's Rutika, I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today we'll be continuing on the topic of sepsis. In the time we spoke about it last, the time I'm recording this, I've come face to face with this increased risk of mortality everyone keeps harping on about. To be honest, I feel like all I'm talking about is death, but I promise, at least for now, this will be the last death story for a while. As a disclaimer, I won't be providing any personalized information, and all names, numbers, and results will be altered to protect the privacy of the patient this story is derived from. So we'll start off with the story before we get into the learning. It was about 3 or 4 days ago from the time of recording, so I've had some time to think about it. We'll call her Pam. She was 91, although she didn't look it, from home with her husband, who was her full-time carer because she had Lewy body dementia and was confused most of the time. I later found out that she was bedbound 23 hours a day and could not look after herself at all. Anyway, this particular day, 3-4 days ago, she came in 8 o'clock as a signal. She had 48 hours of fevers, shortness of breath, she was hypoxic and febrile. Oh, and I forgot to mention, she was in a RAF of about 140 to 200 beats per minute. Now, apart from the soon-to-be obvious fact that a RAF is alarming in itself, max heart rate for a 91-year-old should only be 129 beats per minute, as per the Heart Foundation. So it's obvious from the get-go that her heart is not working properly at all. Anyway, she came in, we got her all set up, got the ECG. We weaned her down from 10 litres of oxygen via the non-rebreather to 4 litres of oxygen via the nasal prongs. Got the fluids going, got the antibiotics running, all within 60 minutes like we discussed last episode. So all was going well. Now I'm going to give you some numbers. She had an irregular heart rate of 180 to 210. BP was okay in the 140s, which was kind of surprising. And oxygen was 95% on the 4 litres, and she was febrile at 38.8. And she had a rest rate between 40 to 48, which was concerning too. The doctor I was working with did an ultrasound of her lungs and her heart before we got the x-ray done and gave me a quick lesson in what we were looking out for. Unfortunately, as I am a novice, I don't think I can really explain it well without showing what I am referring to, but I'm sure there's many videos out there that'll do it better than me. Anyway, he showed me that towards the base of the left lung there was fluid, and he called them like beelines. You're supposed to see flat surfaces, and if there is fluid that the sound waves are going through, it'll show up as a straight line down there. That's how you know that you're looking at fluid. But it doesn't show you what kind of fluid. So it could be a pleural effusion, pneumonia, atelectasis. It's just that there's interference, which comes up distorted on the ultrasound. We then looked at her heart, and he showed me a few images of her left ventricle, her left atrium, and her mitral valve. Now, given her heart rate was 200, that valve was sprinting. But even more alarmingly, her left ventricle was not contracting at all. The walls were quite literally barely moving. They're just, I don't even know how to describe it. They just weren't contracting appropriately. But this meant that there was quite poor cardiac output. If we use the equation we learnt last episode, as there's minimal stroke volume, her body has to pick up the pace big time. The term we use for this is ejection fraction. In basic terms, it is the percentage of how much blood fills and how much ejects. Normal ejection fraction is about 50%. We estimated hers to be about 10 to 20%, which is abysmal. Now, this has all happened between 8 to 9, right? After I gave her some fluids, her heart rate came down to about the 160s to 180s. Still high, but doing much better. We decided to continue on with the antes and give a medication called digoxin. Digoxin, in fancy words, provides parasympathetic innervation to the heart. So what does that mean? Parasympathetic is the rest and digest nervous system, and innervation means to activate the nerve. Therefore, parasympathetic innervation is to activate the rest and digest system, thus lowering the heart rate. Now, IV digoxin is a pushable medication. At this point, her 2 cannulas were used, but they had ports to add medications in. She looked comfortable in the position she was in, so I didn't move her and pushed in the medication appropriately through the line that was running the antibiotics. Now, I just mentioned that she looked comfortable. I think it's important information to discuss her mental state at this moment. Prior to this, she was becoming agitated, which is probably the best word to describe it in this sense. She couldn't sit still, said she wanted to stand, but then, as we know now, I later found out that she physically couldn't stand and was saying that she was super anxious and her nerves were acting up. At the time, I just thought she was becoming delirious, so I told her to lie on her side, like she had told me to, that she wanted to do, and she did, with a lot of effort, but she made it onto her side. After turning, she settled, eyes opening, closing, but resting. But, and a big but, her worker breathing was still severe enough that I could see her taking breaths from all the way at the computer, very easily. Anyway, in the time that she had turned and I had given the dig, she was constantly moving her hand setting off the pump. But her hand had rested in the optimal position, so I didn't move it when I gave the dig. Now, this part of the story needs further context. From the time I gave the digoxin to the end of the story quite literally happened in 5 minutes. No more, no less. At 9:43, I sat down at the computer to write my note. As I'm writing my note, I see her heart rate is now in the hundreds, or thereabout, as it is still irregular, and I'm thinking to myself, digoxin, even IV, doesn't work that fast. By the time I finish my note, about 20-30 seconds later, it's in the 80s. And I suddenly notice it's falling too fast. And that's when I notice as well that her worker breathing just stops. Concerned, I walk over to her. Well, I think I see she's taking shallow breaths. I auscultated her back. Mind you, she's still on her side. And I swear I heard faint breathing sounds. And in that time, her heart rate is now in the 60s and falling. So all in the span of about 30 to 40 seconds, her heart rate has gone from 160 to 60. That is why instead of hitting the buzzer, because I thought she was still alive, I thought I could hear breath sounds, I got my colleague, a senior nurse, to come and check her out with me. I said, I don't feel good about this. We assessed her together, no response. I checked her pulse. There was no radial, no femoral, no carotid pulse. Then I hit the buzzer. We attempted to roll her over and she was proper dead weight, with her mouth hanging wide open. So at this point, I had already pressed the buzzer. Everyone was in the room. We backed and forth for about 5 seconds. I'm like, are we starting CPR? Are we not starting CPR? And I had heard verbally from the doctor that she was goals of care C for symptom and comfort care. But I hadn't had the chance to read the notes. So I was like, I don't know. We need to start CPR. So my colleague started CPR for about 10 seconds before the nurse in charge came running in going, no. She's goals of care C. We need to stop. So we stopped it and called time of death at 9:48, just 5 minutes after I gave the digoxin. Understandably, I was a bit emotional immediately afterwards. I had quite literally just watched a person die right in front of my eyes. And in hindsight, when her obvious worker breathing stopped, I don't think there were any breath sounds, probably just artifact. And it was at that moment that she had arrested and essentially died. In that moment, all I was thinking was, did I do it? Is this my fault? But thankfully, all of my colleagues assured me that it was in fact not my fault. She was critically unwell, 91, and digoxin could not have done that, as well as doing everything else in my power correctly. Now to dissect what actually happened. She had arrested, but we could still see a rhythm on the monitor. If you've listened to episode 2, Principles of ALS, you'd remember talking about a PEA arrest, pulseless electrical activity. There was an electrical rhythm but no cardiac output, which is why, despite her heart rate continuing to fall, there was an evident moment when her overbreathing stopped, when I can pinpoint when she arrested. Anyway, before she had arrested, we got a chest x-ray and it showed left lower lobe pneumonia. She had a lactate of 7.2, and her heart rate and rest rate were alarming as it is. She was febrile, and her white cell count was above 12. She was quite literally ticking all the sepsis pathway boxes. But treatment was not delayed, so there was literally no more we could have done. With all that said, let's dive into the advanced concepts of sepsis and how we see it play out in the case of Pam. So I think I've mentioned VBGs recently. To be honest, I honestly can't remember. But we'll start at the foundations. There are many things a venous blood gas can measure, but the main things we want to look at are pH, carbon dioxide, bicarb, and lactate. This is especially for sepsis. For things like DKA, sodium and potassium are useful numbers too, and for like bleeds, if you're clearing a bleed, HB is an important number. But we're talking about sepsis today, so let's forget the rest of that. pH. The body state is neither acidic nor basic. It's neutral. That is between 7.35 and 7.45. The respiratory component is carbon dioxide. It's an easy range to remember because the numbers are pretty much the same. It's 35 to 45 millimoles. CO2 is an indicator of acid. And the metabolic component, which comes from the kidneys, is bicarb, which is 22 to 28 or 21 to 26, depending on who you ask, and is an indicator of base. How we know what means acid and base. There is a lovely equation that I do not think about at all in my day-to-day nursing and only bring it out of the closet when talking to an educator. It's called the carbonic acid buffering system equation. So you should look this up yourself if you're interested, but the equation is basically H2O plus CO2 turns into carbonic acid, which is H2CO3, which then can turn into bicarb and hydrogen ions, and vice versa. The body is maintaining a constant balance between these two sides of the equation. If there is an excess of acid, the equilibrium shifts to the right, consuming hydrogen ions and forming more bicarb and water, and vice versa. So if your CO2 is up, it's a respiratory acidosis, and if it is down, it is an alkalosis. Alkaline acid. In the opposite manner, if your bicarb is up, it's a metabolic alkalosis because it's a base. And if it is down, it's an acidosis. With these values in conjunction with the pH, we can get a very good understanding of what is going on in the body. And now we talk about compensation. So to maintain this equilibrium, the equation shifts the way we need it to create more of what we don't have. Therefore, if the pH is acidotic and the CO2 is up, our bicarb will need to increase to balance out the acid with more base. This is called a partial compensation. Full compensation is when both CO2 and bicarb are out of range, but the pH has returned to normal. Before we get into examples, it is important to keep in mind that respiratory compensation for metabolic issues will happen fast, I'd say within hours, and you'd see this as an increased or decreased respiratory rate or shallow breath, depending on what the metabolic issue is. But metabolic compensation for a respiratory issue takes longer, and I'm talking like days. And you'd see this as decreased renal function or an acute kidney injury. So let's look at some examples and then delve into more examples for people with sepsis. A VBG we may get for a slightly sick person with pneumonia would be a pH of, say, 7.30, a CO2 of 68, and a bicarb of 35. So if we break it down, our pH is less than 7.35, meaning it is acidotic. Our CO2 is critically high, above 45, which is acidotic. And our HCO3, which is bicarb, I forgot the H, is above 28, which is basic. Putting all this together, we have a partially compensated respiratory acidosis. Partial because the pH has not returned to normal yet. Another example is that a patient presents to ED, we do a VBG, pH is 7.52, CO2 is 28, and bicarb is 37. Our pH is alkalotic, our CO2 is also alkalotic, and our HCO3 is also alkalotic. So what does this mean? This means we've got a respiratory and metabolic alkalosis. So why do we care about these numbers at all? This picture of the body's state is a vital first step to figuring out what is going wrong and what the body is doing to make up for it. That is why in sepsis, it is incredibly important to get a VBG. But one part of the VBG I didn't go into detail on was lactate. This too is a crucial element of VBGs, especially in the case of sepsis. Normal range for lactate is less than 2 millimoles. Everyone's got a small amount of it in their system at any given moment, even when they're fit and healthy. But let's discuss why a high lactate is not normal and potentially an indicator of mortality. To get this fully, we'll have to discuss the pathophys of lactate on a basic level, of course. Cells use oxygen and glucose to create energy we need to survive. Yep. What happens when we either have reduced oxygen or reduced glucose? The body turns to a type of energy making called anaerobic metabolism. Aerobic meaning with oxygen, anaerobic meaning without. This is when it makes a fraction of the energy in the absence of oxygen or glucose. And a byproduct of this anaerobic metabolism is lactic acid, which then becomes lactate, which is measurable. A real-world example of this, and that can happen to any one of us, is when you start sprinting and don't stop. Eventually your legs will begin to ache, forcing you to stop. This is the body's demand for oxygen not meeting its supply. The body started to use anaerobic metabolism, hence the lactic acid in your legs. For all the medicine geeks out there, I recently learnt as well that in shock, the lungs and the heart can be contributors to a rise in lactate too. Catecholamines like adrenaline and their inotropic effects on the heart and beta-2 adrenergic effects can increase lactate production, whether it is produced by the body or supplied externally through an infusion. That's why when people are on adrenaline infusions, you may see lactate continue to rise. I also learnt about a term, occult shock. This is when lactate is high, but you're not seeing a low blood pressure or compensatory high heart rate. This is what was happening to Pam, in a way. Her heart rate was sky high, but that was because of an arrhythmia rather than pure compensation. But her blood pressure, up until the very end, did not fall at all. But her lactate was 7.2, which is critically high. These are the kinds of patients that we need to look out for because their body is failing, but is very good at hiding it. So let's discuss normal shock, which is not occult shock, but normal shock. We say someone is in a shock state when they begin to meet 2 or more of the severe sepsis checkboxes on the handy-dandy sepsis pathway I told you guys to check out last episode. Shock is a state of emergency, and will lead to multi-organ failure and death if not addressed. There are a bucket load of different types of shocks that I'll cover as we go along with these episodes. The septic shock is actually a subcategory of shock. The type of shock septic shock is called distributive shock. This is because the cause of the shock is fluid shifting where it shouldn't be shifting. This is called third spacing and is a little too advanced for today's talk. Another type of distributive shock is anaphylactic shock. Other categories of shock include hypovolemic shock, cardiogenic shock, and obstructive shock. Cardiogenic shock is of great importance today too, and I'll get into why now. As we discussed before, Pam's heart was not pumping effectively at all, and despite her heart rate being 200, it could not have been adequately perfusing the body because it was regurgitating back into the atrium and back into the lungs. Cardiogenic shock is classed as a shock that sort of comes about when the left ventricle stops working efficiently as to provide perfusion for the whole body. Usually when people you see with cardiogenic shock are people that have had heart attacks or are having a heart attack. What I forgot to mention just before is that Pam's ECG showed signs of ischemia, meaning that her heart itself was not being supplied enough oxygen, let alone the rest of her body. So knowing even just the basics of this, we now know that she had both cardiogenic and septic shock. There was pretty much nothing to be done that didn't include invasive and quality of life reducing interventions. So let's move away from Pam knowing that despite my own efforts, there was nothing that was going to save her and let her keep her already dampened quality of life. So we'll change the example. We'll discuss Sepsis Man. It's a great name, I know. And to anyone that is listening and has the capability, please pull up the sepsis pathway from Safer Care Victoria. So, he too has community-acquired pneumonia. Came in with a respirator of 40, oxygen of 85% on room air, and then 99% on 4 litres of oxygen via the nasal prongs. BP of 83 on 58, and a heart rate of 125, and a temp of 39.7. He remains GCS 15, alert and oriented. So if we consult our good old pathway, is there a known or suspected infection? Yes. Does Sepsis Man have 2 or more early warning signs? Yes. He's febrile, his heart rate is greater than 90, his rest rate is greater than 20, and does he have 2 or more signs of severe sepsis? Not yet, because only our BP can be ticked off, but this is already alarming. So let's check the bloods. We've got a white cell count of 24.3, so that's a tick for a white cell count greater than 12. And our VBG shows pH of 7.20, CO2 of 70, and a bicarb of 10, and a lactate of 8.2. This tells us that he's got a mixed respiratory and metabolic acidosis with an extremely high lactate, which also can contribute to metabolic acidoses. Basically, this guy is a little cook. So we get him sorted, we do our 6 and 60 interventions, and have fluid resuscitation and antibiotics going. After 2 bags of 500ml boluses, his fluid... What did I say? After 2 500ml boluses of fluids, his BP remains in the 80s. With his MAP, which is mean arterial pressure, which is just basically it's the area under the curve for BP calculation. It basically tells you the measurement of end organ perfusion. That number itself is falling below 65, which is our benchmark. So what's our next step? Enter inotropes and vasopressors. In essence, they help the heart beat and increase blood pressure respectively. In my ED, the inotrope of choice is adrenaline. It does a little bit of everything. It helps the heart contract with more force, increasing stroke volume, which is the inotrope bit, as well as constricting peripheral blood vessels to increase blood pressure. That's the vasopressor bit. So adrenaline itself will not only increase BP, but it will increase heart rate. But there are some cases where we want to increase BP without increasing heart rate. This is when we use vasopressors, medications like noradrenaline or metaraminol. These do not act on the heart at all, only act on constricting peripheral blood vessels to increase blood pressure. So in Sepsis Man's case, we would not use adrenaline because his heart rate is already 125, and we don't want that to go any higher. So we would use noradrenaline to increase his blood pressure. We as CCRNs can titrate these infusions based on BP. Now that we are tinkering with the BP with this very, very potent medication, and by potent I mean we are infusing in micrograms per minute, ideally 2 to 10 to start off with, but you can increase. And that's a minuscule amount. We've got 60 micrograms per mil because we put 6 milligrams of noradrenaline in 100 mils of glucose 5%. So in 1 mil, you've got 60 micrograms, and we are going 2 to 10 micrograms per minute. So it's not even a full mil per minute. But you get the point. So if we're dealing with these potent medications, we need to keep a closer eye and a more accurate eye on their blood pressure. So how do we do this? Well, we insert an outline. Arterial lines are invasive blood pressure monitoring systems. The ED doctor will place a cannula in the artery, usually the radial artery, and we connect a pressurized fluid line to it. And this pressurized line gets connected to the monitor, and Bob's your uncle. We have constant BP monitoring. So, sepsis man gets an outline. We're giving the noradrenaline and his BP has increased to 105 on 70, with the map above 65. All is well. Well, not really, because this is not going to fix itself unless we get on top of the infection. This is where fast administration of broad-spectrum antibiotics and blood cultures are very important. Now, I feel like I've been rambling for a long time, so if you want to hear more on zeroing, tips and tricks for outlines, and all the different types of tropes, let me know. You can also look up the Safer Care Victoria Inotropes and Vasopressors guideline. They've got a great booklet which I used myself to learn all the different medications and how they work. Another thing I couldn't go into detail or mention at all today was DIC and the Diamond of Death. They are incredibly interesting topics, so I'll dedicate another episode down the line to them specifically. So, to be honest, when talking about the case of Pam, it's only been 3 or 4 days. And to be honest with you, I'm not really fighting myself with this case as much as I was with Bob, if you've listened to that episode. It was a shock when it first occurred, like immediately afterwards. But post some much needed reflection and talks with my seniors, I've come to the conclusion that this was going to happen regardless. It's just a matter of when. And I just happened to give a medication at the same time that her time was up. I literally could not have done it any better or any worse, to be honest. Now, if it was a young person, we would have hopped on the chest and we would have started life-saving treatments. But she was 91. She'd lived a good life and it was time for her to go with dignity. We ended up taking everything off her and laid her to rest. Her family came and said their goodbyes and we prepped her to go to the funeral home. Unfortunately, that day we also had a palliative patient that passed away, so we had to bag, tag, and prep 2 bodies that day. Funnily enough, Pam passed away before the patient that was actively getting ready to die on her own terms, which I do find a little humorous. So, to recap today's Goliath of a session, we discussed Pam, a patient with, by what we've determined, both septic and cardiogenic shock, with some slim chances. We discussed VBGs, what they are, what they mean, and the different examples. We discussed lactate basics, what it means, how it works, and why it's bad. We discussed septic shock and cardiogenic shock and how they relate to PAM. We then talked about invasive monitoring with inotropes and vasopressors with sepsis man. Whew, what a doozy. So, this wraps up this episode of my show Chronicles of a Learner RN. I've certainly learnt a lot with this case and have a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, and what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you, and see you next time.